Good afternoon, and welcome to this session on the COVID-19 pandemic and the consequences for reproductive healthcare services. My name is Hilde Engjom. I'm an obstetrician gynecologist here in Bergen, and I will chair this session together with the moderator Ingvild Sandøy. We will first hear three presentations from international keynote speakers presenting their surveillance and findings from three different continents in both Africa, India, and Peru. And then afterwards, there will be a live discussion with the presenters, and you can also write questions in the chat during the presentations. So please, if you can run the first presentation. Thank you.
I am Salome Maswime. I'm an associate professor at the University of Cape Town, and I'm an obstetrician and gynecologist and the head of global surgery. Thank you so much for inviting me to talk about COVID-19 and during pregnancy. And the title of my talk is the South African Obstetric Surveillance System, the monitoring of maternal and perinatal health consequences of the pandemic for reproductive health services in South Africa. And so I have really been part of various groups that have looked and tried to understand COVID-19 during pregnancy, the impact of the disease itself on pregnant women, but also the impact of the pandemic. And so this quote, I think, summarizes it quite well, that besides the direct impacts of the disease, a plethora of indirect consequences of the pandemic adversely affect maternal health, including reduced access to reproductive health services, increased mental health strain, and increased socioeconomic deprivation. And so it reminds us that as we think about the disease, we need not only to think about what the disease itself does, but what happens during the pandemic and what the outcomes are related to the pandemic. As women don't access the care that they require, as women are not able as women are filled with a lot of anxiety and fear, and may not present for antenatal clinics and may not receive the care that they desire or require in this time, leading to other adverse consequences that we sometimes may not consider. So I'm going to present just a series of papers that I was part of, just as an introduction to the research that we have done in South Africa to understand COVID-19 in pregnant women. And so initially, at the beginning of the pandemic, a lot of the work was focused around whether the transmission, around understanding transmission from mother to child. And as time went on, as it was discovered that there were a lot of pregnant women who were asymptomatic, we started looking at whether we could track the epidemic by doing asymptomatic screening. Some of the challenges with that, especially in low and middle income countries, is the cost of doing the screening on every patient that is admitted either into a labor ward or who is there. And so the guidance on this really is also dependent on the resources and what the healthcare system is able to offer pregnant women. We also realized that in settings where PPE was not available or where it was not being used adequately, there was an increased number of deaths, not just amongst the patients, but also amongst the healthcare workers. And so there was a time where there was a number of obstetricians and gynecologists who had passed away in our country because of, and we believe that some of it had to do with not having adequate PPE. And so we made recommendations for the judicious use of PPE to prevent the spread of COVID-19 in maternity units. The pandemic, of course, has had an impact on maternal outcomes. In South Africa, the maternal mortality rate has gone up by close to 40% during this time, and this was during the lockdowns. So you can clearly understand that it's not just how many women are infected during pregnancy or how they are managed, but it's also the fact that even women that are not, that do not have the disease are also have increased mortality rates during this time because of all of the reduced access to healthcare services, anxieties that women might have with going to the hospitals and receiving routine antenatal care, and also women not always knowing whether they should go or shouldn't go because of the public messaging, which isn't always clear for everyone. We also felt that it's important to continue counting the stillbirths and monitoring perinatal outcomes during this time. As far as I know, there haven't been any clear distinctions between adverse perinatal outcomes between high-income countries and low and middle-income countries, but it's important that we still continue to count and we still try to understand and to see what the perinatal outcomes are during this time. And so we will continue to advocate for this type of work. The other issue that also came up is issues around health systems factors, health system strengthening. And as we've seen that there are more maternal deaths related to COVID-19, or there's an increased maternal mortality related to COVID-19, especially in low and middle income countries. Questions around, are these health system factors, or is it related to the severity of the disease, or is it both? And so important questions around delayed presentation, delayed diagnosis, poor monitoring of vitals within the hospital setting, the shortage of ICU beds for women who might require critical care intervention, shortage of ventilators and oxygen shortages become really important in trying to understand what could have been done differently or what could have prevented the disease or the maternal mortalities related to the disease, particularly in LMICs. So I'm part of the South African Obstetric Surveillance Systems group. And so we did the maternal and perinatal outcomes of the novel coronavirus in pregnancy study, which was funded by the South African Medical Research Council. We're also part of the INOS group, which is the International Network of Obstetric Survey Systems. Our principal investigators were Dr. Samantha Budram, Dr. Valerie Vannevel, and Dr. Laura Yates. And so we started this work right at the beginning of the pandemic, and the study is still ongoing. But for this presentation, I'm only presenting the data from the first wave, which are the results that we had last year when we started the study. So this was a population cohort study, population-based cohort study in South Africa. We had 36 consultant-led obstetric units enrolled in the study. So these were 36 sites across the country in 6 provinces. And we looked at the data of women who were admitted to the hospital with SARS-CoV-2 infection during the first wave. In total, we had 673 women who were admitted during this time. Out of the 673 women, we had 39 maternal deaths, which was a case-fatality rate of 6%, which is quite high if you look at it and compare it with case-fatality rates in other countries, where, especially high-income countries in some settings where women did not die even from severe disease. 106 women, close to 16%, required critical care admission, and so this is quite similar to what is happening in other countries, or at least shows the increased need for critical care admission amongst women who have the disease during pregnancy. And we had 25 stillbirths, 12 early neonatal deaths, and close to 30% of the admissions who went to the neonatal of the babies who went to the neonatal intensive unit. This is quite important for us, but also the bias to note is that not everyone who was admitted in our cohort went to ICU because of COVID-19. There were some other obstetric factors that could have increased the number of admissions to the NICU. Our HIV infection rate was 34%, which is just quite similar or close to the HIV infection rate in pregnancy in South Africa. So this wasn't significant. Tuberculosis was significantly associated with admission in this case, and other comorbidities were not. 63% of the women delivered by cesarean section, 35% of the women had preterm birth, and more than half of the women were obese. And so this is also important to note, knowing that knowing the comorbidities and risk factors for severe disease. So we had a high mortality rate in our cohort, which is consistent with the increased mortality and morbidity rates seen in COVID-19 and in other high and middle income countries. And this really corroborates what we believe, that pregnant women are at high risk for death and for severe disease. And so in closing, our recommendations are that further studies comparing outcomes, further studies are required in our setting, particularly looking at women who have been vaccinated, comparing them with those who haven't been vaccinated. As you know, vaccine equity has been quite a big issue, especially in the African setting, where less than 10% of the population has been vaccinated. And so it's going to take a while for us to get to a point where the majority of the people in our country are vaccinated, and that poses further risks as well for the pregnant population, which has now been prioritized as an important group that needs to be vaccinated, but initially they were not prioritized or seen as an important group with a high risk for severity. So we recommend the vaccination for all pregnant women, and that this is the one way to curb the disease, or to curb the severity and reduce the severity and adverse outcomes related to the disease. We also believe that pregnancy needs to be acknowledged as a risk factor for severe disease in South Africa, and this should also come across clearly to the general population, so that women who are pregnant understand and know that they have risks, and that this is an important, that pregnancy on its own it's an important risk factor. So in closing, I really just want to say that, this is what we have found in the South African setting. We cannot say that this is the case for all low and middle income countries or for other African settings, but we do believe that there might be many similarities with other countries that are similar to us. And so more attention needs to be paid in trying to prevent pregnant women from having adverse outcomes related to COVID-19, and also in ensuring that health system strengthening becomes an important part of the way that we try to manage the disease for pregnant women, that those who require ICU or critical care services or oxygen or ventilators are also able to get the care that they require in order to reduce adverse outcomes. Thank you very much for the time and again for inviting me.
Good afternoon. I'm Ariel Frisancho, a member of COPASA Steering Committee and the Country Director of CMMB Peru. I'm deeply grateful with the 12th European Congress on Tropical Medicine and International Health organizers for this kind invitation. With more than 2 million confirmed COVID-19 cases, Peru is the third country with more cases in Latin America, and the first, globally, with higher mortality ratio per million inhabitants. On September 20th, deaths by COVID-19 reached nearly 200,000. 1 year ago, in March 2020, Peruvian government established a nationwide lockdown with a night curfew. After 6 months, lockdown was finally released. Curfew has been kept. Most non-COVID-19 frontline services were closed. Health facilities had to work with less than 60% of the usual number of health professionals because most of them were sent to their homes due to comorbidities that could complicate their situation in case of infection by COVID. Most hospitals collapsed until late 2020. Moreover, along this period, almost all business except basic grocery stores and pharmacies were closed, and this generated a fall on Peruvian GDP for 2020 of 11.2%. Nearly 5 million people lost their jobs, generating a survival crisis within poor families. Therefore, we had a health emergency with social and economic downturn. However, reproductive health, and particularly maternal mortality, has faced historic health system challenges. At Peru, coexist diverse, multicultural societies with different health realities. We have an incomplete epidemiological transition, which is reflected in the paradox of good national averages as Sustainable Development Goals metrics, coexisting with cruel, stark inequalities and social exclusion. Poor families in Peru are challenged by unequal power relations within our health system, which generate invisible access and quality barriers for them, associated to lack of an accountability culture or better democratic practices, including a very limited citizen participation. All these challenges are not considered in the mainstream global and national policy discussions, or are not considered on the indicators for global policies follow-up as Sustainable Development Goals. Therefore, COVID-19 pandemic worsened an already weak health system, poor resourced and fragmented, with huge inequality gaps, with underlying discrimination and exclusion embedded in health services. For worse, hospital-centric government's approach for fighting COVID-19 underestimated the importance of primary care level. By months, any ambulatory care was closed. So, the consequences of COVID-19 pandemic on reproductive health in Peru were that in year 2020, there were 45.7% more maternal deaths than in 2019. Nearly 20% of those deaths were associated to COVID-19. It was the third cause of maternal deaths in 2020 and the first cause of maternal deaths in 2021. 2021 figures evidence a worse prognosis. It seems we are going to face a 10 years or more setback of our maternal mortality indicators. Most of those maternal deaths could have been prevented by a well-functioning health system, including a responsive primary care level articulated with community leader surveillance of risk signs and symptoms. Maternal mortality in Peru has suffered of the 3 delays model. At home, the lack of decision-making on addressing health facilities as they were closed or collapsed due to COVID-19 emergency. This situation has doubled the number of unsafe home deliveries in Peru in recent years. Second, challenges to reach the health facility due to limited transport and difficulties for making a timely referral to hospitals with solving capacities and intensive care unit beds. Third, the delay on having proper attention in overcrowded hospital services with less than 60% of health personnel working, already overwhelmed by the situation they are facing. Other causes are the extremely limited access to antenatal care services and the limited access to modern contraceptive methods. All these services have reduced its impact and coverage in recent years. COVID-19 has unveiled previously unrecognized inequities in our healthcare systems. We have to bear in mind that health emergency has come with social and economic crises within households that already were challenged by poverty and poor social determinants of health. A main lesson is that one size doesn't fit all. Although the efforts of Peruvian government, they should not have relied only on already collapsed hospitals or complex solutions, underestimating the importance of primary care level for identification, contention, and management of cases at the community and proper referral. The need of a strong, context-appropriate, participatory, quality primary healthcare systems. Third lesson, not confusing universal health coverage with universal health insurance. We need to ensure not only a registry, but genuine universal access to good quality services, addressing national and local inequalities and excluded populations. Fourth, the importance of citizen participation and community engagement, but listening to them, understanding their needs, understanding their possibilities, and providing them security. Therefore, we need a new approach to community health agents and young leaders. And mention young leaders because adolescent pregnancy is a main challenge for almost all Latin American countries. Fifth, social communication as a paramount strategy, but locally adapted with messages that are appropriate to their realities and their possibilities. 4 of each 10 households in Peru don't have water. We cannot be giving messages that are appropriate for urban places or higher position families, but we need to address their needs and give them solutions, appropriate solutions. Fifth, the importance of health personnel availability and health personnel mental health. The pandemic has taken a significant mental and emotional toll on health professionals. We need to address that. Finally, 2 questions for afterwards. How will health systems should look like after COVID-19 pandemic? What's the role of virtual communication as we are having in Peru with community health agents of virtual networks to ensure the continuity of care? No? Which are the opportunities of telemedicine in these environments? Which things need to change in health systems that seems to be functioning well, but they are not. And second, the need of regional and global solidarity and the role of academia in this. Thank you very much indeed.
Hello everyone. I'm going to talk to you about reproductive health crisis sparked by COVID-19 related lockdowns in India. I'm Manisha Nair and I'm an associate professor at the University of Oxford. So many of us are aware of the devastating impact of the COVID-19 pandemic in India. Millions of people were infected by the virus and hundreds of thousands of people lost their lives. While we are aware of these direct effects, it's important to understand the indirect effect of the pandemic on reproductive health and care. There were 2 studies that were published using data from the first wave and each from a single tertiary hospital. Both studies showed a significant decrease in hospital births, but there was mixed evidence about the impact on maternal deaths. They were not able to provide detailed evidence of the impact and trends across the first and second waves. We believe that it's important to understand the impact on reproductive health and care in India, particularly because this country already has the second highest number of maternal deaths in the world, and about 45,000 women die each year as a result of pregnancy and childbirth-related complications. We know that serious concerns were raised by experts and international organizations at the beginning of the pandemic about the impact of lockdowns on access to sexual and reproductive health services, with predicted rise in unsafe abortions and decrease in access and demand for care. A meta-analysis published in a systematic review showed a 37% increase in maternal deaths during the first wave of the pandemic compared with the pre-pandemic period. So to examine the impact, we use data from an ongoing repeated monthly survey undertaken through the Matri platform. I'll talk a little bit more about this platform in the next couple of slides. Clinically confirmed cases and deaths as a result of 9 severe maternal complications are reported via the Matri platform each month from 15 hospitals across 5 states in India, and this survey has been continuing since August 2018. But the data that we used in our study covered a period of 30 months from December 2018 to May 2021. And this covered a total of more than 202,000 hospital births. We divided the reporting period into 4 phases to compare hospital births, incidence rates, and case fatality across the phases of the pandemic with the pre-pandemic period. And these phases were constructed using the data from the Johns Hopkins University. We also used the Government Response Stringency Index scores computed by the Blavatnik School of Government, Oxford, and the scores for India were used to measure the impact of strictness of lockdowns and other restrictions on case fatality, incidence rates, and hospital births. So, Matri is a UK-India collaboration for maternal and perinatal health research. And we have 3 key objectives. One is to routinely collect data on the prevalence of known and emerging pregnancy complications. Second is to conduct large-scale hospital-based epidemiological studies to generate evidence to improve the clinical management and outcomes for pregnant women. And third is to develop, strengthen, and share research capacity between the 2 countries. As mentioned, the collaboration currently includes 15 hospitals across 5 states in India. These hospitals are both public and private hospitals, and they are also both community and tertiary hospitals. I have included a reference to our paper if you need more information about the platform and the methodology that we use to establish the platform. So this is the case reporting form that we used for the survey, and it includes these 9 severe maternal complications. As I mentioned, the survey is undertaken in 15 hospitals, which together conduct about 100,000 deliveries per year. There were 4 important findings from the study. The first was that there was a significant decrease in hospital births per month during the pandemic period, with a 5% decrease per 10% increase in the stringency index. As you can see from the graph, the maximum decline in hospital births was during the first wave, when the first wave was rising, and this also corresponded with one of the strictest lockdowns in the country. Overall, during the pandemic period, there was a decrease of about 30 to 35% in hospital births. The second important finding was that while overall incidence of severe complications in the pandemic period was not significantly different from the pre-pandemic period, case fatality was 23% higher. We believe that there are two reasons for this. One is that only women with very severe complications were coming to the hospitals, and perhaps quite late. And second was the effect of the pandemic on the availability of obstetric services, as many obstetric units were converted into COVID-19 treatment centers. Another important finding was that hospital admissions from septic abortion was 56% higher in the pandemic period, and it showed a linear association with the stringency index. This indicates that women did not have access to contraception and safe abortion services during the rising first and the second waves of the pandemic, which also corresponded with strict lockdown measures undertaken to mitigate the rising waves. Finally, the case fatality remained high across the phases of the pandemic and was not significantly associated with the stringency index. Therefore, the evidence that we have generated supports the legitimacy of the calls made by the WHO, other international organizations, and scientists to maintain sexual and reproductive health services as essential services. While India is preparing to manage a third wave of the pandemic, the country needs to take urgent action to mitigate the ongoing reproductive health crisis using the lessons learned from the first and the second waves. We have three key policy recommendations from our study. First is that the sexual and reproductive health services should not be affected by lockdowns. We urge the government to keep public and private clinics offering contraception and safe abortion services open during lockdown and periods of strict restrictions with adequate staff. We all know the obstetric emergencies require rapid evaluation and interventions, so there should not be any delay in pregnant women traveling and reaching the health facility. India has a good network of government ambulance services, and some of these ambulances can be kept as priority services for pregnant women. Each district could have a designated obstetric care hospital that is COVID safe. We know that public messaging is really important because many women feared contracting the virus and therefore did not come to the hospitals. A simple message like severe complications in pregnancy can be life-threatening if treatment is delayed. So don't delay, get help from your nearest health facility could be important in raising awareness about the ongoing reproductive health crisis in the country. This work and the Marty Research Platform is funded by a Medical Research Council UK Fellowship. I'm thankful to the Marty collaborators and the staff who've made this work and other studies undertaken through Marty possible even during the pandemic. This slide has a link to our website, where you will also find the Marty quarterly newsletters, where we will be publishing an update on the incidence and case fatality during the pandemic period going forward. And finally, there's also a reference to the paper that I presented in this talk. So thank you very much for listening to this talk.